Hi, everyone. Thanks for attending my girl session today. I have the code that is QETLOZ to text for CE. And the presentation today is titled The Short Guide to Deprescribing. Here we go. All right. And so sorry, I just lost video. Can everyone see my screen here?
Yes, looks good.
Okay, sorry, I don't know what just happened. Okay, so going over the objectives today, we'll review the definition of deprescribing and discuss the importance of the deprescribing concept and just like it's important in elderly patients. And then also kind of piggybacking off of that, going over the differences between pharmacokinetics and pharmacodynamics and how that plays a role in the elderly. And then finally, going through some resources available to assist with deprescribing. All right, so we'll start with the patient case here. We have KJ, who is a 76-year-old male and is new to the home-based primary care team. As a pharmacist, you complete the initial CMR and find the following. So he has a past medical history significant for hypertension, hypothyroidism, peptic ulcer disease, overactive bladder, depression, anxiety, osteoarthritis, and fibromyalgia. His current complaints are the fibromyalgia pain that is not controlled at a score of 7 out of 10. And he also has some worsening depression and feeling more tired overall. You complete the MedRec and you update the medication list, which is on the right-hand side here for you. And I'll give you guys a chance to just kind of skim through those medications. And as we go through this presentation and keeping these medications in mind, as we discuss different deprescribing options and tools, just thinking about what interventions we could make for KJ to optimize therapy and hopefully help treat his current complaints. So what is deprescribing? Initially, when we hear this word, or when many of us hear this word, we might think that it's the complete discontinuation of the drug itself, but it can actually be more than that. By definition, it's the planned and supervised process of a dose reduction or stopping of medication that might be causing harm or no longer be beneficial to the patient. So essentially, reducing the medications that may have a higher risk versus benefit. And the ultimate goal of deprescribing is to minimize polypharmacy, decrease the risk of adverse events, and in doing so, improving patient outcomes. So I mentioned polypharmacy, and deprescribing and polypharmacy can sometimes go hand in hand. A lot of the time, the concern for deprescribing or polypharmacy can trigger the deprescribing process. So I'm sure many of you are familiar with the term, but as a reminder, it's the simultaneous use of multiple drugs to treat a single or multiple medical condition. And this can lead to a larger medication profile, use of potentially inappropriate medication, also known as PINs, under use of medications, so meaning that we're not getting to therapeutic doses before adding on therapy and optimizing that medication, and then also possibly duplicative medications. So taking a step back to see how polypharmacy exactly comes about, I want to talk about the prescribing cascade, which is a series of events where a patient sees a provider for a medical condition and is prescribed a medication. They can then have a side effect of the medication or multiple side effects that can be misinterpreted or misdiagnosed as a new or separate medical condition. And in trying to treat the new symptoms, the prescriber then adds on another medication, and we can see, and that medication could be avoidable, and then the patient might have more side effects to the newly added medication, which again could have been avoidable. So this cascade can happen multiple times within one leading event, leading to polypharmacy. And we have many studies showing the link between polypharmacy and an increased rate of adverse events, especially on our elderly patients. They are at a greater risk of them because they oftentimes have multiple medications due to the multiple conditions that they might have. And then they also have some physiologic changes that alters drug metabolism, leading to the accumulation of medications and also leading to more side effects. So there are some risk factors that have been identified for patients who are more likely to experience polypharmacy, and these include adults who are 65 or older, those with cognitive impairment or behavioral issues. A lot of the times, finding a balance for medications in these disease states requires the use of multiple medications, and their uses can overlap, so we'll see some polypharmacy there. And in some cases, the lack of a PCP can also be a huge factor in patients having multiple medications. They might be seeing multiple specialists instead of having one person that is kind of the go-to for maybe like primary care disease states. And then you have specialists with the lack of a PCP, you'll have specialists who are trying to treat primary care disease states, or might be thinking that one person is managing versus another. All right, so we have our first assessment question here. Which of the following are reasons for elderly patients being more prone to adverse drug effects? Options are A, polypharmacy, B, age-related changes to pharmacokinetics and pharmacodynamics, C, cognitive decline, or D, all of the above. And I will give you guys a moment to put things in the chat. Okay. Oh, wow. Okay, so I'm seeing some D's come through. And that is correct. So we know that polypharmacy is kind of a multifactorial thing, and all of these are definitely factors that can play a role in this. So now we'll get into discussing pharmacokinetics and pharmacodynamics. So just to review some definitions, pharmacokinetics is what the body does to the drug. So how it interacts with the drug through the entire course of drug exposure. And this includes, you might have heard it as LADME or ADME, which is absorption, distribution, metabolism, and excretion. And then pharmacodynamics is kind of the opposite of that. So it's what the drug does to the body and the physiologic effect that the drug has after the whole receptor binding and the downstream effect of receptor binding and the protein interactions that the medication has with the body. So when we're talking about pharmacokinetics, the characteristics of the drug and how it interacts with the site of action kind of controls the effect that the drug has on the patient. And the intensity and duration of drug response is dependent on the rate and extent to which the drug is absorbed from the administration site and the volume of distribution and eventually elimination, which are all factors that can be affected by the patient. And pharmacodynamics can be affected by the physiologic changes in the patients as well. So some medical conditions or disorders and gene mutations can alter the receptor binding site, which then alters like drug binding affinity and the drug receptor sensitivity. Aging has also been shown to cause alterations in receptor site binding, and then responsiveness to therapy is altered there as well. And finally, with all the medications that a patient can be on, there are drug interactions that can result in competition for receptor binding and alter post-receptor responses that way. So here is an overview of pharmacokinetics in older adults, and we'll go through each of these section by section. So starting with absorption. Older adults experience a decrease in small intestine surface area, and this is where we have a majority of our drug absorption. So the smaller our surface area is, the less drug absorption we'll have. And so it might decrease the efficacy of the medication and in some cases require higher doses. Slowed gastric emptying can also affect absorption. We need medications to leave the stomach so that they can be absorbed, and this would mostly affect medications that have a shorter half-life. And then as for the pH, we know that we have some pH-dependent medications that require an acidic environment for like optimal absorption of a drug. So another point that can be affected. For distribution, as we age, there is a greater body fat content in comparison to total body water. So here we'll see most of our lipophilic drugs that are affected. So it can increase the elimination of them. When we have lipophilic drugs, they'll stay in the tissue longer and then or possibly have a negative impact on the patient with experiencing toxicities. Protein binding can also play a role for some medications. So albumin levels are generally lower in the elderly. This could be due to like diet, malnutrition. So for highly protein bound drugs like phenytoin or warfarin, we might see more toxicity associated with them when the albumin is low because there's more free drug floating around. And finally, elimination. For hepatic metabolism, there is a decrease in liver mass. So this means that there is usually decreased blood flow as well. And when we have that decreased blood flow, we have less first pass metabolism. So we have less of the drug circulating in the body that's making it through the CYP enzyme system to be metabolized and broken down. So again, we might see some accumulation here and some toxicity that can be experienced. And lastly, due to decrease in kidney function, heavily renally eliminated medications tend to accumulate in this population and cause adverse effects just because their older adults are not as efficient at excreting these medications. So all of us here can play a role in deprescribing. On the inpatient side, the initial med rec is super important when a patient is being admitted. Once we have a solid list of a medication that a patient's taking and we know what they're coming into the hospital for, we can use that list to review and assess to see if any of their medications are there side effects of the medications or toxicity that they might be experiencing that could be contributing to the current ailment. And then on the flip side of that, upon discharge, we can make sure that the patient is counseled appropriately on medication changes that were made, if any, and then also working with the inpatient team when reviewing the discharge medications to see if there is any opportunity for therapeutic optimization or just like a deprescribing opportunity that might have been missed by the providers. In the community setting or ambulatory care setting, since there's more face time with the patient, this is a great opportunity to get a medication intolerance history or allergy history and discuss exactly what reaction a patient is having to those medications. I think this is super important because since we're talking to the patient directly, we can get a more clear history and we don't necessarily have to rely on outside records or documentation made by others. And then also utilizing our DURs that come through as opportunities to fully review the patient's med chart and make any changes, assess the need for therapy, and contact the provider and provide follow-up on that. So we talked about the importance of deprescribing and the fact that we can all play a role in it, but how do we go about that process? There's no set guideline, as mentioned before, for deprescribing and like what's the correct way to go about it. So I found this image here from a family practice management journal article that I think is very comprehensive and gives us a better idea of a starting point for deprescribing. So identifying which medications a patient is taking, looking at why it could be inappropriate, if there's a lack of efficacy, are they experiencing any side effects, are they actually benefiting from the medication? So overall, there's 4 steps. It starts with completing that initial medication reconciliation, which we review the med list with the patient and also include any over-the-counter items or supplements that the patient is taking And then while we're reviewing this med list, also trying to make an assessment of how well their disease state is controlled for the indication of therapy. And once we complete this and we know what our patient is taking, we can kind of identify and see how well medications are working for them and identify which medications may be inappropriate, unnecessary, or harmful, or lack efficacy in general. And there are different tools that we can use or like different deprescribing tools, I should say, that we can use to help us make this decision. And I'll mention those a little bit later on in the presentation. So once we've identified these medications, then we could actually educate our patient on deprescribing, so that shared decision making is super important. We want to make sure that we are providing our patient with all the information regarding safety and efficacy. And then for more hesitant patients, we can also let them know that there are tapering approaches to medications to help get them on board. And then letting them know that we will closely be monitoring them to see if there's any breakthrough effects of their disease state, and then adjusting therapy as needed. And so successfully deprescribing isn't always a smooth process, and there are some barriers and bumps that might come up along the way that I want you guys to be aware of and anticipate and plan for before intervening. So a couple of the biggest ones I kind of touched on earlier are getting providers and patients on board. So for example, if we have a patient that is new to a provider, they might not want to make any changes right away when seeing the patient. But I think when we are reviewing the patient chart as well, it wouldn't be wrong to at least point out or speak to what possible interventions are, so that it's at least on their radar. They might not necessarily act on it right away, but they'll keep it in the back of their mind for things to address in the future. And then from a patient perspective, you might have patients, for example, with chronic back pain or pain from other chronic conditions, who usually get put on multiple medications to help manage. And it's gotten to a point where they're on a handful of medications and don't know exactly which one is providing the most benefit. They might be a little bit more hesitant to come down, but I think those are excellent opportunities. And to have discussion with the patient we can try coming off solely for each of these medications, because this is what you could experience, this is what harm can be caused, and that way we can identify what medications are actually helping you and keep you on the least amount of pills as possible. And then another barrier that we might come across is that lack of evidence and guidelines for deprescribing. So while we do have data supporting decreasing polypharmacy and reducing adverse events that way, we don't have set guidelines for how to do that. So it's mostly based on clinical judgment, which can cause some hesitation for providers, but this is where our extensive drug knowledge can be super helpful in knowing their safety and efficacy profile for a given disease state. So now we'll get into our deprescribing resources. And there are a ton of resources out there, but today we'll go through only 4 of them. And I would say that these are the most commonly used, and together, if you're using even a couple of these, are pretty comprehensive and can provide you with enough support to make a clinical decision. So we'll be going through the Beers-List criteria, the anticholinergic burden score, deprescribing.org, and MedStopper. So starting with the Beers-List criteria, the criteria are meant to be applied to patients 65 and older at all points of care, except when a patient is receiving hospice care or comfort measures. Ultimate goal of the Beers-List criteria is to reduce the exposure of older adults to potentially inappropriate medications or PIMS. And as a result, the expected outcomes are improvement in medication selection, a great opportunity to also educate clinicians of why medications could be potentially inappropriate, reducing adverse drug events, and then by reducing adverse drug events, also decreasing healthcare costs related to possible readmissions, and also just from the dispensing standpoint with copays of medications. The American Geriatric Society, so the AGS, is the organization that updates the Beers criteria. I think they do that every 3 years, so pretty regularly. And they have identified different causes or reasons for a medication to be identified as potentially inappropriate. And I have them listed here for you. So medications that can be inappropriate for older adults based on drug syndrome interactions and possibly exacerbating the disease or syndrome. Inappropriate medications that should be used in caution with older adults. So if we see that older adults are having more side effects to medications and highlighting specific side effects that they are at risk of having. There are potentially inappropriate medications for drug-drug interactions, so just combinations that we want to avoid. And then also medications that should be avoided due to a decreased renal function in older adults. So here is an example of what the Beers criteria kind of looks like and how it's organized. So for each PIM, they have a separate table, and I have one here for the inappropriate use of medication in older adults for drug syndrome interactions. So for example, here we have heart failure listed, and then they have the list of medications that can exacerbate heart failure, and they note whether to avoid or use with caution, and then the quality of evidence supporting that recommendation. And because there are so many drugs and tables included in this resource, if you were to open it up, it's literally, you'll have the introduction and then all these tables and then some explanations as well. So a lot of the times you resort to using the Control F feature. And just a little tip for this is that the medication name might not specifically be listed. It could be categorized by the drug class itself. So for example, here I have the PPIs. You don't have specific medications like omeprazole or pantoprazole listed here. So if you were looking for one of those using the Control F feature specifically, you would miss the recommendation on the proton pump inhibitors. So just something to keep in mind when you're using this resource is to, if you can't find the medication, try to look for the drug class because it might show up that way. And then here is, I think this was the result of another resident project, and I want to say it was Jess, so shout out to Jess if you played a role in making this report available to us. But this is a report that's been super helpful. It's a built-in Beers Lists report in HealthLink, and you have to be in an encounter to access it. So once you're in the encounter, you go to the Snapshots tab, and then in that search bar, you type in OP Beers criteria medications, and it'll list out drugs that are in the patient chart and categorize them based on the PIM or potentially inappropriate medication or adverse event of the drug if it's in the Beers list criteria. And then another nice feature of this is that it actually links to the guidelines. So that American Geriatric Society Beers criteria, if you click that, it'll actually open up the guidelines. So it saves you some Google searching that way. The recommendations are also colored according to severity, colored and organized, I should say, according to severity of the recommendation. So if it's something that should be avoided, it'll be red and listed at the top of the report. And then if it's used with caution, lower priority, so it'll be orange. And then those that just kind of require monitoring or more of a note to think about will be listed in blue on the lower side of the report. Our next resource that we have is the anticholinergic burden score. So anticholinergic drugs are ranked on a scale of 1 through 3, with 3 being the highest anticholinergic burden due to higher serum concentrations of anticholinergic activity or higher binding affinity of muscarinic receptors. And we worry about these medications, especially in the elderly, because they're more susceptible to having these side effects. And for those who are visual, I found a nice diagram here of anticholinergic side effects at different parts of the body. And just to comment on some of the more common ones, are constipation, dry mouth, urinary retention, delirium, confusion, blurry vision. So those are things that we want to avoid in our patients, especially in our elderly. And here's an image of what the actual resource looks like. So we see that it's split up into 3 different categories based on scores. So 1 being the lowest anticholinergic burden and 3 being the highest anticholinergic burden. So what's nice about this is that it can provide us with it can quantify the cholinergic burden and kind of help us determine our own level of severity based on that number. And then also it can provide you with lower anticholinergic burden activities. So if you can't find a medication that would be an appropriate alternative, or if it's a medication in a similar drug class, you can look for an alternative that has a lower anticholinergic burden. And then one kind of downside to this resource, however, is that I think it was last updated in 2012, and we've had a lot of medications come out, so it might not be the most comprehensive and updated list, including medications that have some anticholinergic activities. So we could possibly be missing out on an opportunity of assessing the anticholinergic burden. Okay, so time for another question. What is KJ's ACV score? So I have the medication list here for you, and then all of their medications that do have anticholinergic burden should fall under the score of 3 that I have a snippet of over here. So I'll just give you guys some time to look through that and see what the score would be. And I can't really see the chat, Allie, so if any, oh, okay, there we go. All right.
We have the two C's, a lot of C's.
So exactly. So the patient's anticholinergic burden is 9, which is C. So that's correct. And that's actually a pretty high anticholinergic burden. So definitely some room for therapy optimization or changes to be made. And that burden is coming from trospium, nortriptyline, and diphenhydramine, all having a score of 3 each, totaling 9. All right, so moving on to deprescribing.org, which is another great resource that has information not only for healthcare members, but also patients. So this is something that we haven't seen from our other sources, or the other 2 sources that we talked about so far, is having those patient pamphlets and information for them. I think it allows for an opportunity to have shared decision-making between the patient and the provider. So if you go under the resource tab, you'll find some links to deprescribing algorithms, some case reports of adverse events that happened if from a certain medication that could have been avoided, and then again, those patient education pieces. So one limitation with this tool is that it does provide great deprescribing guidance, but it only provides deprescribing guidance for a few drug classes. So I have them listed here with the proton pump inhibitors, antihyperglycemics, antipsychotics, benzodiazepine, and cholinesterase inhibitors. And for each of these classes, they will have a deprescribing guideline or algorithm, which I can show you on the next slide. They also have patient education material, as well as videos on deprescribing and counseling on each of those drug classes when deprescribing. And I just want to highlight the medications that fall under the antihyperglycemics are sulfonylureas and insulin. For the antipsychotics, you have a mix of first gen and second gen antipsychotics, so haloperidol, aripiprazole, clozapine, quetiapine, olanzapine, and then benzodiazepines are all oral benzodiazepines. And then the cholinesterase inhibitors include donepezil, galantamine, and memantine. So here's an example of one of the algorithms that you'll find, and they all have the same general layout. starting with the indication for therapy and then when to deprescribe based on symptom control or side effects. So for example, going through this one, starting with indication, if a patient doesn't have indication like Barrett's esophagus or chronic NSAID use with the GI bleed risk, we can recommend deprescribing. And we can start by either decreasing the dose if they're on a higher dose of the PPI or stopping completely and possibly switching to like as needed use. And then with each of these algorithms, they will also provide you with like a general time frame for when to check in with your patient to reassess for symptoms. And then another nice thing is that if you look below that, they also give some non-pharm interventions that patients can make. So outside of your pharmacologic intervention that you're making and dose reduction or taper, whatever you choose to go with, you can also provide patients some lifestyle things that they can change to help maintain disease state control. They also include some drug information, so they'll go over general dosing for a given indication for the medications, what side effects or withdrawal symptoms you can expect, if there's any breakthrough symptoms, what that might look like, and then also just tons of information regarding like deprescribing and monitoring, as well as like patient education, again, which is something that we didn't get from the other two resources so far. And then I guess one of the downsides of this resource is just that it doesn't contain such a comprehensive list like the Beers list criteria and only focuses on some drug classes. And the last resource that we are going to talk about is MedStalker, which is more of a clinical decision support tool rather than guideline, but it does also incorporate other sources and link out to other sources like the Beers list criteria because it takes into consideration information from that resource, and you can use that to make your recommendation as well. So it provides clinical support in terms of assessing the likeliness of a drug to cause harm, and if it were to be discontinued, how to go about doing that. This is an image of what the home screen looks like. It allows you to also account for like frail elderly, which I think is nice because they are at an increased risk rather than just in comparison to elderly of having more side effects to medication. And then you can type in the name of the medication. I like that it allows you to, or it'll pick up on the brand name or generic name of the medication. I don't know about you guys, but sometimes your brain just can't think of one or the other. So it's nice that it picks up on both. And so once you have entered the medications from the patient's list into the source, this is what a screen will look like. So on the left-hand side, both of these medications are high priority, so you'll have the red colored boxes, but if there were different priority items, I believe the other options are like yellow and green for like moderate and then lowest priority item to address. So it also gives you just like what it allows you to like decide what you want to prioritize intervention wise. And so once you have the medications entered, there's some fun images that go along with the risk versus benefit. Will it improve symptoms? Is there more harm that could be caused? And the risk of like future illness. So how well it will provide disease state control. And then when we are looking to discontinue medications, it recommends, it provides information on if a taper is required, how quickly or how slow to go down on the taper, and then also if it's needed in general or not. Another nice part about this is that it provides you with some withdrawal symptoms that a patient can experience while coming off of the medication. So you can just get all your information from that one spot to educate your patient on. And then finally, like I mentioned, on the right-hand side there, it does have the Beers list recommendations. So when you click the details button, it'll link out to or like pop up exactly what the recommendation that's listed in the Beers criteria will be. So again, it kind of saves you an extra search for if you wanted insight from multiple resources. And I kind of mentioned some pros and cons of each tool as we went along the way. And here's just kind of a summary chart for each of them for your reference. It can help you decide which tool would be the most beneficial for a patient situation. So if you're simply looking for potentially inappropriate medications for elderly, you can start with the Beers list criteria and see what category or level of severity the medication falls under for the patient. If you're looking for a possible taper recommendation, depending on the drug, you can use MedStopper or Deprescribing.org. If you want additional patient information, Deprescribing.org would probably be the most helpful. And finally, if you're looking at a patient's medications, and this more so goes for the elderly again, because a lot of these resources do focus on them. So you notice the patient is on a lot of anticholinergic medications and want to see what alternative options there are. The ACB score can help you with that. So coming back to our patient case here, I know I had you guys kind of think about what interventions you'd make. So given their current complaints of the fibromyalgia pain, the worsening depression, and feeling tired, and knowing what we know about deprescribing and what tools we can reference, what interventions would you make for KJ? And I'll give everyone some time to put their thoughts in the chat. Remember, his ACB score was pretty high at 9, so maybe there's some changes that we can make with that. Saw some Benadryl for sleep, which is a great one. Does anyone else have any other thoughts? Okay. So I have listed here some possible interventions that we can make for the patient. So starting with their PPI, they they do have an indication for peptic ulcer disease, but that's not necessarily like an indication that requires chronic long-term use of PPI therapy. So if the patient's symptoms are controlled and they say they have like a recent EGD that showed that they're clear of any ulcers or erosion, we can try to stop this medication and put them on like as needed acid reducing therapy and see if he tolerates that. It was mentioned that we can cut back on the Benadryl and finding an alternative. So yeah, definitely we can recommend melatonin for sleep. And I think oftentimes we do see this on a lot of our elderly patients' profiles. For the pain and worsening depression, we can kind of tag team this. So nortriptyline that the patient was on has an ACB score of 3, so one of the higher ones. So we can try to switch this to duloxetine to see if it can help with both the pain and depression. Given that the patient's pain is from fibromyalgia, data supporting the use of tramadol for this type of pain isn't super strong. So this is another intervention that we can make. And we know that the patient's symptoms aren't controlled anyways, and they are taking the tramadol. So we can just stop that altogether since it's not really doing anything for the patient. And finally, for the overactive bladder, we can switch trospium to mirabegron or Myrbetriq to decrease the anticholinergic burden as well, since that also had a score of 3. And he's also on hydrochlorothiazide for blood pressure, which is diuretic therapy. So we can see if we can either go down on the dose of this or try to take off the hydrochlorothiazide, see how his blood pressure is doing, put on an alternative medication if we need to, and then see if this also helps with his overactive bladder symptoms should he ever complain of any. All right, so that's all I had for you guys today. I'll open it up to any questions that you might have about different resources to use or the case in general. And then I also have the code here to text for CE in case it was missed earlier.